Liver transplantation is an established treatment for an end-stage liver disease with a 95% 1-year survival rate and 80% in 5-year survival rate. There are multiple causes for the liver transplantation. The first and the topmost is cirrhosis, secondary to either infective hepatitis or maybe because of development of hepatocellular carcinoma. The second cause is autoimmune disease, in which there is great requirement for the liver transplantation. The third reason, which is usually seen in European and Western countries, these are alcohol abuse, and the fourth cause is Alagilla syndrome. In Alagilla syndrome, this is actually a congenital disorder which affecting heart and liver the most. The one important point to be noted is that the majority of donors' liver are of cadaver origin. There are three types of the procedures available. The one is called a split graft procedures, in which the cadaver liver is used. A single organ donation or that benefits either 2 or more patients. So usually the left lateral segments for a child is used and the right lobe for an adult recipient is used, but mind you, this would be from the cadaver origin, and this is called as split graft procedure for the liver transplantation. The another procedure is from the living donor. The living donor, they donates the full right lobe, which is very common, or sometimes they may donate the full left lobe. Again, it is less common, but left lateral segment can also be used for the liver transplantation. Especially the donor would be living, and it would be used from the living donor. The third procedure is called as axillary transplantation. It is also called as piggybacking, or a graft along the native liver as a temporary measurement. It is used only for the reversible liver failure. If someone is suffering from reversible liver failure, which can be corrected by putting small small part of the liver alongside of its native liver, which is also called as piggybacking, and it will reverse the normal liver function. So these are the three types of the liver transplantation is available. The split grafting procedure is usually from the cadaver origin, and then the living donor, and the axillary transplantation. There is criteria for the liver transplantation, whether this recipient can be benefited from the liver transplantation or not. So for that purpose, one has to identify and characterize the focal liver lesion. This is especially used in the patients who have already having cirrhosis, and there is a great chance of developing of hepatocellular carcinoma. So if the patient's having a lesion, single lesion less than 5 centimeter, or he have 3 lesions less than 3 centimeter, so he can be benefited with the liver transplantation. If any lesion greater than 5 centimeter or more than 3 lesions greater than 5 centimeter cannot be benefited from the liver transplantation because of its rejection or some other complication. So to identify and characterize the focal lesion in patients with having a cirrhosis with less than 5 centimeter single lesion or 3 lesion less than 3 centimeters can be benefited with the liver transplantation. 1 to 2 different imaging techniques are required to identify HCC in the cirrhotic liver, because only on one imaging techniques it cannot be assured whether there is possibility of HCC or not. So there are 2 different techniques should be used to confirm the presence of HCC and their size and the lesion size. Biopsies usually avoided due to the risk of tumor seeding. There is likely chance if you take the biopsy, so there will be a seeding and this will go elsewhere and spread and metastatize. So the liver biopsy is not recommended if there is individual waiting for the liver transplantation. The liver transplantation is rarely performed with cholangiocarcinoma because there is poor prognosis, so that's why those who are having already cholangiocarcinoma, they are not the good recipients. So rarely the liver transplant is performed with cholangiocarcinoma cases. After identifying the liver status and the liver lesion, it is important to look for the patency of portal vein. If it is occluded, so then it is important to look for the confluence of a superior mesenteric vein and splenic vein, whether these both are involved or not, because it will affect the surgical approach. Next come the IVC. The extent of the involvement of the IVC is very important if there is Budd-Chiari syndrome, because Budd-Chiari syndrome has three categories, three gradings. So one has to look for the category of the Budd-Chiari syndrome, which level and which degree Budd-Chiari syndrome is. It is important to identify the anatomical variants, especially hepatic arterial anatomy. However, the portal anatomy is of less value. So for that purpose, one need to have MRA, arterial MR, and CT angiography can be used to assess variant hepatic arterial anatomy to confirm whether there is some anatomical variant or not. After confirmation of any of the pathology, the living donor should be looked for the left lobe, because the left lobe is usually resected. Increasingly, the right lobe sequence and segments are removed, but there is greater chance of mortality. Cross-sectional and three-dimensional imaging techniques are used to detect variant of the arterial, portal venous, hepatic venous, and biliary systems of the donor, so to avoid any abnormalities and to avoid the graft rejection. Perioperative imaging is used to detect the early complications like hemorrhage, hematoma formation, and abscess formation, or sometimes it happens then there may be an anatomic breakdown. It is also allow images guided drainage and aspiration. You can correct these abnormality by image guided drainage and aspiration. Surveillance imaging is performed regularly for high risk groups, for example pediatric transplants and those with a complex vascular reconstructions. It detects sudden complications and that can be respond to an immediate intervention. For example, hepatic arterial occlusion, if arterial occlusion, hepatic arterial occlusion occurs, so it can be easily corrected. Early graft failure can be due to primary non-functioning. Hepatocyte functions fails to recover in the newly performed graft despite of vascular patency and good perfusion at the time of surgery. So it is influenced by hepatic steatosis. When there is hepatic steatosis, there is a great chance of primary non-functioning of the hepatocytes, and as a result early graft failure occur. The second reason is hepatic artery thrombosis. It's usually seen in 3 to 5% of adult, but it's very common in children, especially 5 to 15%. We can see that the children's develops early graft failure. So Doppler ultrasound is important to find the diagnosis, and if there is catastrophic liver failure and infarction, so there will be abscess formation, there will be bleeding complications as well, there will be a leak or even stricture formations, and sometime it would be silently, there will be no obvious sequel. So this is what hepatic arterial thrombosis can cause the early graft failure. However, portal vein thrombosis and IVC occlusions are rarely seen as a result of early graft failure. Acute rejection is also very infrequent because of improved immunosuppression drugs, because patient is already taking immunocompression or suppression drugs, so that's why acute rejection is very rare. The another reason is overwhelming sepsis. If there is any overwhelming sepsis, this would be the reason of the early graft failure. Causes for the late graft failure includes chronic rejection, maybe because of chronic ischemia, biliary anastomotic failure, diffuse biliary disease due to sepsis, recurrence of underlying disease. For example, it may be primary sclerosing cholangitis, or maybe recurrence of hepatitis C infection. So these diagnoses are often made on biopsy. So these were the causes for the acute and chronic, or acute or late rejection of the liver transplantation.